to this edition of the DY Patil Postgraduate Lecture Series. Today we have with us one of our old faculties, Dr. Avinash DeSouza. He is an avid teacher, apart from being a dear friend and a good psychiatrist. And we are also happy to have with us Dr. Nikhil Chaugule, who's a person known to me for a long time. He is the professor and head of Prakash Institute of Medical Sciences at Islampur, which is close to Kolhapur. And he's also a consultant psychiatrist at Swastik Hospital at Kolhapur. I've had the privilege of knowing his father, who's a very prominent psychiatrist at Kolhapur for decades now. And we thank Dr. Chaugule and Dr. D'Souza for making the time to be with us today and sharing with us their thoughts. Dr. Avinash is going to be talking about a very interesting topic, rating scales in psychiatry, which is relevant to all of us at a training level as well as at the clinical level in our practices. So I will request Dr. Chaugule to take over and introduce Dr. Avinash D'Souza and get the proceedings going. I shall come back at the end of the program to give my vote of thanks. Over to you, Avinash and Nikhil.
Thank you so much, sir. Good evening, everyone. At the outset, I would like to thank Department of Psychiatry, DY Patil Medical School, Navi Mumbai, for giving me this opportunity. So today's topic is rating scales in psychiatry. As Rashmin sir had already spoke that it's very important. Rating scales, they play a very important role in the field of psychiatry for the accurate assessment of the patient, even for the diagnosis, as well as planning the treatment, progression. Along with that, rating scales, they are structured and standardized way to evaluate patient symptoms, severity of the illness, and as well as response of the treatment over time. So it not only enhances the clinical decision making, but also it plays a vital role in supporting clinical research. So without wasting much of time, I would like to introduce today's speaker, esteemed speaker, Dr. Avinash D'Souza sir, to give us detail about various rating scales in the field of psychiatry. I think so. As PG students, it is very important to introduce rating scales or to know details about the rating scales in the field of psychiatry so that it can be used in their clinical practice as well as in their various research which they conduct during their postgraduate training program. So over to you, sir. Dr. Avinash D'Souza is a very well-known psychiatrist of Mumbai, as well as he is a clinical associate at Sion Hospital, Mumbai. So I would request Dr. Avinash D'Souza to continue and take over. Avinash D'Souza, sir.
Yes. Are my slides visible?
Yes, sir.
Yes. Okay. So I am primarily going to focus on psychiatric rating scales in adults. If we have time, I have added slides on child rating scales also. So let us see how we can fit it into the time up to 6 p.m. If I'm able to fit it in, then we'll do both. Otherwise, maybe child may be another talk altogether in detail. Let us see how that goes. So what are we doing today is we're going to discuss...
Extend it a bit, Avinash. You can feel free to take extra time. There's no problem.
Yeah, I'll just see. Mostly, I think it should fit in. Let's see. Yes. Okay. I'm going to discuss the various psychiatric rating scales that we use in practice. Basically, where, when, how, why these scales have to be used. How does one gain confidence in using these scales? What is the role of assessment of a patient? And the need for these rating scales in psychiatry. So when we look at the different types of rating scales, we have some self-rating scales. They may be scored by the clinician or the patient both. Not all are scored by the patient, but there are self-rating scales. There are physician-rated scales which are scored especially by the physician. Then we have scales which are diagnostic. The whole aim of the scale is that we diagnose a psychiatric disorder. And there are some scales which are symptom based, where the focus is on symptoms, on the symptoms that the patient is facing and what is sort of going wrong. We also have scales that may be rated. There are some scales which are nursing scales, which may be rated by the nurse on duty or by the nursing staff, primarily so that the doctor gets an idea about what's been happening to the patient. So all sorts of scales are available. It's very important. Nursing scales are rarely used in our system, but we should use them more often. The aim is to quantify the observation and observe the changes as treatment progresses. Now, I assume many of you who are attending have seen some rating scale or the other. And if you look at rating scales, you have two types of scales. You have categorical scales, which are yes and no kind of scales. So no is when let's say there is no depressive symptoms, and one is when there is depression. So there is just yes or no answers. You have scales which are what we call interval scales or Likert type scales. So you rate the symptom or the thing as 0, 1, 2, 3, 4, 5, 6. So right from no depressive symptoms to very severe depression, depending on a scale. And the third is something called a visual analog scale. So there are some figures given. So depending on different emojis, your pain could be rated from 0 to 10, or based on different crying emojis, sadness could be rated from 0 to 10. So you have visual analog scales, you have interval scales or Likert type scales, and you have categorical scales. It is very important to understand that an inventory is very different from a scale. So we all know of a psychological test we use called the MMPI, which is the Minnesota Multiphasic Psychopathological Inventory or Personality Inventory. Its inventory is when you have true or false questions. They are open-ended questions. There is no quantification. Whereas a categorical scale is where there is quantification to some extent, and it's more yes and no. So we go straight to the different scales. The entire lecture is going to be about a large number of scales. The presentation has been mailed to the organizers. It will be put up on the website. If any one of you wants the presentation, I will send it to you. So these are all we're going to talk about various different scales used in psychiatry. So it's an overview of everything. So when we look at rating scales in depression, we all have heard of the Hamilton rating scale. It is the original and to many still the best. As you can see, around 200 papers a year come out with its citation, and it was there in the 1960s, but a lot of people felt that the Hamilton scale was more symptom based. Now it's important to understand that the rating scales which we have mentioned here is used after we clinically diagnose. These are not diagnostic scales. These are scales to rate the severity. So once you have diagnosed, then we use these scales to rate improvement on psychotherapy, improvement on medication, improvement overall. So the Hamilton rating scale is the most commonest. Then, of course, Aaron Beck, when he came up with his cognitive theory, came up with the Beck depression inventory. It is preferred, but what is liked about it is that it has more cognitive emotional components than only symptoms. So people prefer the Beck depression inventory, and on Hamilton and Beck, both you get mild, moderate, severe, or no depression. You get those kind of categorizations. So the BDI has also been used. There is something called the Hospital Anxiety and Depression Scale, which is a very specific scale given by Zygmunt and others in 83. The whole aim of the HADS is that it rates anxiety and depression in admitted hospitalized patients. So if you work in a general hospital and you have medical patients that are admitted, it rates anxiety and depression in that patient. So it's also been something which is actively used in general hospital studies. A more recent scale that came up in the early 1980s was by Montgomery and Asberg, the MADRS, or the Montgomery-Asberg Depression Rating Scale, which is a symptom-based scale, and it was derived from the Comprehensive Psychopathology Rating Scale. Why people like this scale is it's symptom-based and it's been used the most in clinical trials. If you look at any clinical trial papers, the MADRS is something that has been used more. Zung came out with a self-rating depression scale, which is still widely used it's a patient-rated scale. Then, of course, specific scales came out, like the geriatric depression scale came up primarily for older adults because they felt the symptoms are different from that of younger adults. We had a hopelessness scale came by Beck, and we all have studied in psychiatry that hopelessness is a marker for suicidality. So Beck's hopelessness scale was used in depression patients to make out the level of hopelessness so that you could look at suicidality as a factor. A scale for postnatal depression, the most commonly used and the most established scale is the Edinburgh Postnatal Depression Scale, which was done at the Edinburgh Hospital, given by Cox and Holden in 1987. They gave, of course, a sort of revised version of it in 2003. Martin Seligman, we know, spoke about learned helplessness, and he believed that in depression, sometimes your attributional styles matter. So he had come up with something called the attributional style questionnaire, but that is something we don't use so often. What's very important is a lot of people talk about depression and dementia coexisting, and it becomes very difficult to sort of identify depression in patients with dementia because they already have cognitive impairment. And that is where Alexopoulos et al. Came up with the Cornell scale for depression and dementia, which was in the Cornell University. And it's a very special area. So you have a very special scale for that. Along with depression scales, we have certain life event scales which are very important. We've all studied something known as the Holmes and Rahe life event scale, which has been the famous scale. There was an Indian version for it, which was the Gurmeet Singh scale developed at Patiala. But there's also something known as a life events and difficulty scale, the LEDS. There is something called the multiple affect adjective checklist. Now, this is a very interesting scale by Zuckerman because these checklists are used to, they are different adjectives to, give your mood states. Whether I feel low, I feel blue, I feel sad, I feel hopeless. So different adjectives. And the checklist is used to look at those different adjectives. There is a self-assessment depression inventory called the Wakefield one, which is now replaced by the HADS. There is also something known as the premenstrual tension syndrome scale, which is also now used for PMS. There was a LEAD scale, dementia mood assessment scales. There are multiple scales. There's also a scale by Berrios, which is for guilt. Primarily, a lot of patients with depression have guilt. So this is something which is used over there also. Moving on from here, for mania, we have fairly lesser scales compared to depression. So the most common, the best, the most widely used in all clinical trials also that you do for bipolar disorder is the Young's Mania Rating Scale. Young is a lady who has come out with a large number of scales. One of them is the Young Mania Rating Scale. There is the Young Scale for internet addiction. There is a Young Scale for smartphone addiction. So the same group has been coming out with a large number of scales from an early period. There is one scale which is by Betch, not Beck, Betch Rafelson Rating Scale for mania. It's a not so common scale, but used. And you also have a clinician rated scale for mania, the CARS-M, which is fairly new and not widely used. The YMRS or the Young's Mania Rating Scale has been used the most. When it comes to looking at old age symptomatology and dementia, the most common scale we've used is the MMSE. It's available in Hindi, Marathi, many Indian languages by Folston in 1975. It's a bedside test. It's a clinic OPD test. You can know the scale by heart also and use it. So there are 30 points, out of which a score of below 25 indicates dementia. So the MMSE is the most commonly used thing. We now have replaced the MMSE with the Addenbrooke's cognitive examination, revised, and that has 100 points, out of which 30 is the MMSE and 70 are other points. So the Addenbrooke scale is a more common scale that we use now. MMSE alone is not used. There is also something known as a clinical dementia rating scale for all dementias, which was given by youths. There's a scale for ischemia known as the Hachinsky's ischemia scale, which is primarily meant for vascular dementia or post-stroke dementia. You have the blessed dementia scale, which is used for memory and focus. There is a global deterioration scale by Reisberg, which is very important because that gives you an idea about global deterioration in general, how the patient is deteriorating. And particularly for dementia patients, you have an index of activities of daily living. This is not cognitive, but it gives you an idea of ADL, how independent the patient is, how dependent the patient is, and how that is progressing over a period of time. Jeffrey Cummings, which is a pioneering figure in neuropsychiatry, has come up with something known as the neuropsychiatric inventory, the NPI, which is a paid test, but it is one of the classic tests to assess neuropsychiatric symptoms in general. You have specific scales for Alzheimer's, which is the Alzheimer's disease assessment scale. So once you've diagnosed Alzheimer's, you could sort of look at that. You have a short portable mental status questionnaire, not so used so often. There's a modified MMSE also, which has come in, which is shorter than the normal MMSE. There is an interview by Roth known as the Cambridge Mental Disorders of Elderly Examination, not so commonly used, but done there also. People with cognitive failures, they have a cognitive failure questionnaire, and a large number of neuropsychiatric inventories have been there, but the most common one used is the ones by Cummings. Whenever you have a patient with delirium, sometimes it becomes difficult to assess and judge. So there we have something known as the delirium rating scale, which is come out in 88, and it's something that is a very widely used scale to judge delirium. What is the level? And it's to be done daily, so you can plot whether delirium is improving or not. Similarly, there's a scale only for relatives, which is the informant questionnaire on cognitive decline in the elderly. So you can make out over a period of time whether cognitively the patient is declining or improving. It's an important scale. And you also have the Sandoz clinical assessment. Sandoz was a pharma company that sponsored the development of the scale. So it's a Sandoz clinical assessment for geriatric populations. Cohen and Mansfield came up with an agitation inventory for delirium, only to judge how much agitation is present and to assess autobiographical memory specifically. And we use this in ECT also to assess autobiographical memory. We have the autobiographical memory interview, which is given by Koppelman. There are different scales, and you should ideally, whenever you get a patient with some disorder, just apply a scale, look at how it is to be used. There are YouTube videos, there are a lot of articles available, and use the scale. Even if you make a mistake, it doesn't matter. The important thing is you get a feel of the scale. Always remember, you will not get comfortable with the scale unless you use it in at least 30 patients. You have to use the same scale in 30 different patients to get comfortable. You could use it, ask a fellow resident to use it so that you get an idea of how you all to differ on the rating. So it gives you some idea. Today we see a lot of patients who have differences in attitudes in eating disorders. So we have what is called the body dissatisfaction subscale for eating disorder. So it's a part of the eating disorder inventory, but it looks at only body dissatisfaction, which is very important. You have an eating attitudes test or an eating disorder inventory also that can be used. A lot of people want to screen psychiatric populations for binge eating. So you have a binge eating questionnaire that can be used in this group. There are a lot of patients who go in for plastic surgery and cosmetic surgery in a private setup, and we get referrals for those, whether these are genuine cases of patients who want change or is it primarily psychopathological, and should they go in for surgery or not. So there is something called the body shape questionnaire that is also used. There is a body dysmorphic disorder inventory called the BDDI, which is also used. You have a Dutch eating behavior questionnaire for eating disorders and an eating disorder examination. You have an eating disorder questionnaire which has 6 questions, which can be used as an OPD screening. We've recently done a study using that at San Hospital. So we have multiple eating disorder questionnaires that can be used. You have multiple scales for binge eating disorders. You have specific scales like bulimia test, that is a bullet, which is the most commonly used test only to diagnose bulimia or the presence of bulimia in general populations. You have the anorexic behavior scale to look at anorexic behavior in psychiatric patients. You have a structured interview, which is a paid scale by Fisher. It's a structured diagnostic interview to diagnose anorexia and bulimia. This is based primarily on DSM. And you have the body attitudes questionnaire by Bentovim and Walker, which is very important. It tells the person's attitude towards his own body shape, size, body satisfaction, etc. Similarly, we also have the body satisfaction scale that plays an important role. You have certain, now we go towards some diagnostic scales, and these are very important scales because these are not available free. They have to be paid. Some of them are online, some of them are offline, but they are diagnostic in disorders. So we've always been using the structured clinical interview for diagnosis, DSM-3R and now DSM-4. DSM-5 also has come in. So the SKID is for DSM-5 now that we use. and it has been used the most in diagnostic interviews, but it's a long scale. It takes a long time. So unless you have the finances to manage it and you have the time to conduct that kind of research, it's not something that is very feasible. Earlier there used to be a skit 2 up to DSM-4 for personality disorders till DSM-5 when the axis 1 to axis 4 component got eliminated. So that was there. There is something known as a present state examination, which is primarily based on ICD, and it's a diagnostic interview by ICD. DSM-4 and earlier used to have something called the global assessment scale, which was an axis of pathology in DSM, but it could be separated into just knowing what the global assessment of functioning is. There was something called a general health questionnaire, GHQ, which if you type online, it has been used in a large number of screening studies. In fact, they say it's the doyen for quick screening. It's the best test for quick screening of common mental disorders. So when we conduct general epidemiological studies, we use the GHQ. It works much better. There are some scales which were used earlier. This is a scale that is my favorite, and I have used it a lot in my early years of career and research. That is Symptom Checklist 90 and by Derogatis, and it is a very popular quick assessment. 90 questions, you get around 10 different scales, and you get an idea of psychopathology. There is also the Hopkins Symptom Checklist, which is 45 to 48 questions, similar to Symptom Checklist 90. Recently, there's been a CIDI, that is the Composite International Diagnostic Interview, CIDI, which is used. Wing came up with a very good scale, which was the successor to PSI, known as the SCAN, that is Schedules for Clinical Assessment in Neuropsychiatry. This gave a comprehensive assessment of psychiatry and neuropsychiatric disorders. And there was the Comprehensive Psychopathological Rating Scale, known as the CPRS, which had subscales of depression, anxiety, obsessional, schizophrenia pathology, which gave you a beautiful idea. And the eating disorder inventory was derived from the eating disorder component of this comprehensive psychopathological rating scale. They have certain scales that looks at needs. So there is a Camberwell assessment scale for needs. What are the needs of the patient? Camberwell assessment scale for need in elderly. We don't use the Candid anymore, but there is some other scales which is important. That is, when a person uses mental health services, is he happy with the services? Somebody came out with a consumer satisfaction questionnaire to know how happy the person was. And there is also, very interestingly, a scale by Amador, which has not been used often, but to assess the unawareness of mental disorder, particularly patients who have no insight, to assess how bad is their lack of insight. So scale to assess unawareness of mental disorders has also been there. You have a specific scale for psychosis, that is the Burkwood scale for insight in psychosis. Berrios came without a simple scale for insight in general, and a patient satisfaction questionnaire for mental health services. These are very important in treatment intervention studies. When it came to suicidality, there were a lot of scales which were available. So we had the Beck's hopelessness scale, which was the first one. Beck came out with a scale for suicidal ideation, only to assess ideation. There was also a scale for suicidal intent. How much is the intention in one's life? There was a scale for assessing suicide risk that came up. Post-attempt risk assessment, that is, what are the chances of risk after an attempt? Risk of repetition. These are all scales which are available and can be used. And scale for assessing suicide risk of attempted suicide. So particularly patients with borderline with repeated attempts, what is the risk? And a parasuicide scale for non-suicidal self-injury, which also has been used. There are a lot of scales in the sexual domain also that have been used. So we have the sexual interaction inventory, which primarily looks at sexual interaction between the couple. How is their interaction? Is it proper, not proper? What is the kind of sort of general interaction that they have? There is a specific scale for measuring the intimate bond. How intimate are they? Only the intimacy component is measured. So we have the intimate bond measure. You have people who look at only arousal. So the sexual arousal inventory may be looked. Sometimes you look at different components of sexuality. So the multiphasic sex inventory may also be used. Sometimes people have repugnant attitudes towards sexuality that could hamper sexual function. So the multiphasic, the async inventory for attitudes towards sex. This is from the famous Hans Async, who gave us the Neo 5. Similarly, Async's inventory for attitude towards sexuality was there. Derogatis, who gave us the SCL 90, had a sexual functioning inventory also that looked at sexual function. There is also an inventory for sexual satisfaction. This is used in marital couples, and a sexual experience scale. There are specific scales for orgasm. There are specific scales for erectile dysfunction. There are specific scales for anorgasmia also. So one can use these scales to rate how the patient is. When it comes to alcohol dependence, it's very important. We see so many patients with alcohol dependence, and we must use a very simple scale known as the audit. We've all studied it in our post-graduation, and the alcohol use identification test. It's been cited the most, used the most. We also have MAST, which is the Michigan Alcohol Screening Test, which can be used, and the CAGE questionnaire. Everyone knows the CAGE questionnaire. It's there in Kaplan as well. So these are things that we should know and use with our patients. Severity of dependence scale, particularly for all drugs, that is heroin, amphetamine, cocaine, etc., has been there. There are multiple alcohol dependence scales. There is an Anton scale, ANTON, Anton scale for alcohol craving, which is used primarily. And you have an addiction severity index by McClellan. McClellan is a very famous personality in substance use. He was the editor of the Journal of Substance Abuse Treatment, Arthur McClellan. And he gave us the addiction severity index, which only looks at what is the severity of addiction as a whole, and hazardous drinking patterns, particularly patients who come to you with an emergency, alcohol, delirium, etc. You have the Paddington alcohol test. Now, there are a lot of short tests which are used. I'm not going to go into those details, but you have an opiate withdrawal scale. So you can use it to rate opiate withdrawal. Subjective and objective, both are there, and both should be used. You also have a benzodiazepine withdrawal symptom questionnaire, which you can use if you have patients with benzodiazepine withdrawal in your practice. And severity of opioid dependence, as well as subjective dependence, which can be used to rate opioid dependence, which is very, very important. There are multiple scales used to rate anger and aggression also. So you have a Bus, Durkee, hostility, and guilt inventory, which is important for anger. The most common used one is by Spielberger, that is the state trait anger expression inventory. This looks at anger as a state and anger as a trait. Trait is something which is over a long time, and state is something which is over a shorter time. There's an overt aggression scale which is there. The MMPI has a subscale of aggression. It's an accessory scale that can be used. And personality disorder examination by Loranger is the most commonly used personality disorder screening tool, diagnostic interview tool, which gives you an idea to what personality disorder is used. A common scale I use in my practice is something known as a Novaco anger inventory. The Novaco anger scale gives you an idea about different types of anger and what leads to it, what is the cause of it. So it's a very useful scale. There are multiple other scales which are used for social interaction. There is a scale where the staff could observe aggression, a borderline syndrome index for borderline personality, self-esteem scale. The most commonly used is the Rosenberg scale, and we of course have Robson scale also that can be used. You have a checklist for positive and negative symptoms in schizophrenia. You have a checklist for schizotypal personality, specific scale for schizotypal that can also be used. Now, anxiety we spoke about, and you have quite a lot of scales for anxiety, and one of them is the hospital anxiety depression scale that we spoke about. But what's very important is the most commonly used scale is the state trait anxiety inventory. We had a state trait anger inventory. We also have a state trait anxiety inventory that looks at anxiety state and trait both. The YBOX, the Yale-Braun obsessive compulsive scale, is very, very important. It's the most commonly used scale. You have an obsession score, you have a compulsion score, and then you have a comprehensive list of obsessions and compulsions that can be ticked. And this is important because it gives you very good data for therapy, very good data for pharmacological intervention, and you can monitor the patient on it every 2 weeks. Why it is called Yale-Brown? Because University of Yale and University of Brown came together. Yale and Brown are not the names of authors, they are the names of universities. You have the Beck anxiety inventory, which was given by Beck, more cognitive-based scale for anxiety. Hamilton anxiety, like we spoke about, more a symptom-based scale for anxiety. And Taylor measured trait anxiety. Trait anxiety is a trait, as a stable personality trait. That is the Taylor Manifest Anxiety Scale, which was a better scale for trait anxiety. You also have people who are, afraid to mix socially. So you have the social avoidance scale. There is also something known as the Lebowitz scale for social anxiety. You have an adult version and a child version. So the Lebowitz scale for social anxiety is something that is also used. You have body sensations questionnaire, primarily for those with panic. What are the different body sensations that they're getting? You have an agoraphobic cognition questionnaire for agoraphobia. A mobility inventory for how much is he moving out of the house now? How much better is he? So mobility inventory for agoraphobia. Fear survey schedule, which is primarily for phobias. How much is someone afraid of and what is he afraid of? And Zoom anxiety scale, which is more a self-report scale. There are some other scales which are very important, particularly you have the trauma questionnaire, you have an obsessional inventory by Layton. These are not so commonly used. You have a structured clinical interview for dissociative disorders, again, something that we don't use more often. The MHQ, which is for dissociation, again, we don't use so often. So these are not so commonly used scales. We move ahead to sleep disorders, and I think something which is very important is we do the multiple sleep latency test, which is the most common thing. But of course, you have sleep questionnaires. So sleep questionnaires and assessment of wakefulness, which is a commonly used scale to rate how sleep is and how wakefulness is. There is also sleep evaluation questionnaire that looks at sleep pattern and the quality of sleep. You have the Stanford sleepiness scale that looks at sleepiness in general, and you have an excessive daytime sleepiness scale, EDS, that looks at EDSS, that looks at excessive daytime sleepiness in general. So these are the sleep scales that may be used. There are scales that look at chronic fatigue syndrome, which I'm not going to go into so much. The McGill pain questionnaire is the most common questionnaire used to rate pain-related psychological factors. You have an health anxiety inventory for hypochondriasis. There is also a scale known as Whitley's Hypochondriasis Index, the WHI, which has been used most in studies. We used it, I think, 4 years back in a study that we did at Cyan. And the illness behavior questionnaire is something which is there for hypochondriasis that you can use. You have some combined scales which are very important. So you have a schedule for affective disorders and schizophrenia, very, very commonly used in many studies. The BPRS, or the brief psychiatric scale, the oldest scale, many merits, but it may be less relevant now to newer diagnostic practice changes, but it's still very, very commonly used. You have the PANS and the SANS and the SAPs, which you all must know. Please use the PANS in at least 30-40 patients with schizophrenia. Use the SANS and use the SAPs, very important. You have scales for dissociative experiences. You get many patients who complain of odd dissociative symptoms. And in those patients, you can use the dissociative experiences scale to screen normal patients, to screen normal adults, to screen psychiatric patients for dissociative experiences in an OPD setting. Whenever a patient is put on antipsychotics, and let's say he develops EPR, you have a scale for akathisia, which is the Barnes akathisia rating scale, the most common scale, particularly now when patients with cariprazine complain of akathisia. We've used it to try and rate how the akathisia is bad. You have a tardive dyskinesia rating scale if TD develops. You have AIMS, the abnormal involuntary movement scale. You should use this scale in any patient with EPR. Keep a copy, Xerox of it in a file. When you go in the night, you see a patient with EPR, use the scale, do all the exercises on the scale, get an idea of how to use it. It's a very, very important scale for EPR, and you should know how to use it. I now move on to certain scales for children, particularly, which I think are important. So you have the Children's Global Assessment Scale, which is to look at global assessment of children between the age of 4 to 16 years. It's clinician rated, 100 items. It takes around 5 minutes. It's free, so it should be used. These set of slides, that is the child scales, have been borrowed by from a presentation by my good friend, Dr. Alka Subramaniam, who presented on child rating scales. I took a permission today and I'm presenting these scales from her presentation. For children and adolescents, you also have a functional assessment scale to rate how they are functioning, performance-wise, thinking-wise, mood-wise, behavior-wise, even caregiver-wise. And this is between the age of 7 to 17, and they have a different version between the age of 4 and 6. It takes 10 to 30 minutes, Likert type scale, clinician rated. The drawback is it is a paid scale, so you'll have to purchase it and then use it. You have the Columbia impairment scale to rate child and adolescent impairment between the 9 to 17 years of age. It has 13 items, and you have a parent and child version. You don't need training for it. It's free. So this is something you could download and use. You have both a parent and child version. There is a DICA, that is a diagnostic interview for children and adolescents. This is a computer-based test. The algorithms are computerized. It is clinician and self-rated, but it's paid. You have to buy it online, keep it online, use it online. So the cost of these tests are very often very high. You have a child CBCL, which we use, the most commonly used test, the child behavior checklist for 4 to 18 years, 120 items. It looks at school behavior, activities, psychopathology, social behavior, school, oppositional defiant behavior, aggression, ADHD. And this is a paid scale, but it's one of the most commonly used scales also. There's also known as a strengths and difficulty questionnaire. This is a very important questionnaire in school settings that we use. This gives you an idea of the strengths of the child and the difficulties the child is facing. It's a brief behavioral questionnaire for the age 4 to 17. There are 25 items on it, and you have teacher versions which are also available, your parent versions and your child versions, and this is absolutely free and can be used. So you also have the the behavioral assessment scale for children known as the BASC. So you have teacher rating scales for preschool child and adolescent and parent rating scales for preschool child and adolescent. However, this is paid. As you can see, ADL, adaptability, aggression, anxiety, attention, conduct, multiple domains are assessed, and it is something that also can be tried and used. We have heard of VSMS, that is a Vinland Social Maturity Scale, which is a substitute for IQ, and IQ is not possible. It gives you the social quotient. We have something known as a Vinland Adaptive Behavior Scale, which looks at 3 domains. That is the communication domain, receptive communication, expressive communication, and written communication. The daily living domain, that is personal, domestic, and community, interpersonal relationship, playtime, leisure time. And this is a survey. It's a parent version and a teacher version for children less than 6 years of age. It has around 383 to 433 items. It's a huge scale, but it's a paid scale, and one may have to purchase it and buy it. We all know about the Wechsler Intelligence Scale for children, and now we are using the WISC-4. The WISC-5 has also come, and we're using the WISC-4. So that's a very good intelligence test for children that should be used. There is something known as the RAT, which is the wide range achievement test that may be used. It's used between 5 and 94 years, but it's used for reading, writing, arithmetic, and it gives you a good idea about how good they are. Similarly, you also have the Woodcock-Johnson's test that could be used to assess LD. It's a standard battery. Pearson is selling these batteries. And you have the dyslexia assessment for languages in India. This is a paid test. It's available in Hindi. It's available in Marathi and Kannada. This is something that can be used. It's cheaper than Woodcock-Johnson and the others. The Niemann battery for LD is something that you could look at. It's recommended by Government of India, but you need to be trained by Niemanns for this. So you need to meet them, undergo training. For ADHD, we use the Connors rating scale, which is the best scale, I think, for ADHD. You have a child version, a parent version, and a teacher version with 10 to 20 minutes, and they can be used very, very easily. There's a long version and there's a short version. It's not so expensive. We have other scales for ADHD. That is a SNAP, Swanson, Neal, and Pelham questionnaire, which is used since 2001. We have a Vanderbilt scale, which I use in my practice a lot, which has a parent and child version and a teacher version also. And strength and weaknesses of ADHD symptoms. The UTA scale is not used so much. If you look at ADHD scales, this is an overview. You get the Vanderbilt scale, you have the SNAP, you have the adult ADHD report scale, particularly for adult ADHD. You have a scale for comorbid screening known as the WACE ADHD comorbid screening and for functional impairment. And you also have medical monitoring scale. This is a very important scale to monitor efficacy and side effects of medication. Medical monitoring scale, which you can use when you're giving atomoxetine or methylphenidate in patients. There is a modified checklist for autism in toddlers known as the MCHAT-R, a 20-item scale for screening tool less than 2 years, which you can use. It's free and available online and can be used very well. The CARS is a paid scale which has been used all this while for 2 years and above. It's a 15-item clinician rating scale in a parent form. You have a CARS HF, which is for high functioning autism. But we use in our practice today something known as the ISA, the Indian Scale for Autism. It has 6 domains. It's absolutely free. 40 items. It has Hindi version also. It gives you an idea of disability also. So it's a very good scale. The modified overt aggression scale, which I described, can be used for aggression in children between the age of 6 to 17. It's also free and available online and can be used a lot. You have the children's aggression scale, the teacher version, where the teacher can talk about verbal aggression, aggression against animals, unprovoked physical aggression, weapons, etc., which is a paid version of the test. And of course, we have different scales for anxiety. You have the Spence's child anxiety scale, the preschool anxiety scale, the state rate anxiety scale for children. There are multiple scales for anxiety. You can choose based on your preference. You have the Beck's depression inventory, which is for 13 to 17-year-olds. The children's depression inventory, which is the CDI-2 now, which is from the original CDI developed by Maria Kovacs. You have between the age of 7 to 17, it takes 15 to 20 minutes. It's not very expensive, but at the same time, yes, you can afford it, and it's something that should be used. And it's a very old test and a very reliable test. There are free rating scales that are the mood and feelings questionnaire for children, depression self-rating scale for children. You have the Kutcher's adolescent depression rating scale, which is also there. You have the schedule for affective disorders and schizophrenia mania items, particularly for children, to look at grandiosity, which is also free, and you could use this. There is a childhood trauma questionnaire to look at trauma, 28 items paid, and a pediatric emotional distress scale to look at the emotional distress following abuse or trauma. These are useful scales for therapy, more so. So we have multiple rating scales which are available. It is totally up to you which scale you want to use. Please look at different scales that are available. Decide why you want to use them. Look at their applicability to your patient, and then go ahead with using them. You choose based on what exactly do you want to measure. Do I want to measure ADHD? Do I want to diagnose ADHD? Do I want to treat ADHD? Do I want to look at symptoms? Do you want to look at side effects? Do you want to look at something else? You have to be very specific when you choose your scale. It has a very important role in research, but more so in clinical practice. It gives you an idea of improvement. You can argue with patients about improvement also. Many patients say there's no improvement, but when their scores on a scale reduce, it indicates improvement. You need to be aware of these scales. There are innumerable scales. According to me, there are over 1,000 rating scales available online. So it's up to you. And those of you who do clinical studies and research and clinical trials will use more and more of these scales and get trained in more and more of these scales. And the more you use these scales, the more you will learn about them. Thank you so much. If there are any questions, I'll be very happy to share.
Thank you so much, sir. Thank you so much for covering, almost all these rating skills in the psychiatry within a span of, let's say, 50 or 55 minutes. It's really difficult to, incorporate everything within the given time. But I think so students might have got a complete overview of rating skills in the psychiatry. Sir, I have one a question to you.
Yes.
As you have already narrated, scales, the different various scales related before adults or for children, let's say for depression, anxiety, mania, OCD, sleep disorders, suicidality, sexual behavior or sexual functions. But are there any rating scales, specific rating scales for LGBTQI community to assess their anxiety,
Yes.
depression,
So
or
nowadays they've come up with mental health scales for LGBTQ populations also.
okay,
So you have one scale for depression screening, you have one scale for anxiety. They are developing a structured clinical interview for mental health issues in the LGBTQ plus community. There is a scale for homophobia. There is a scale for transgender phobia, which has been there. There has also been a scale for um, uh, coming out of the closet. Are you ready to come out of the closet or not? That kind of a scale. There is also a scale for homosexual anxiety, which you may see in some patients in practice. They also have a specific scale for queer sexuality and queer sexual pleasure, which is also there. And a gender fluidity survey is also available. So there are different scales.
Thank you so much, sir. I request PG students, if they have any questions, please post in the chat box or you can ask.
Can we get the PDF for the slides? You mean the PPT? Yes, you can get it. I will send it. I've already sent it to the organizer. I think Rashmin has it on his email and he'll forward it to all of you all or put it up on the website.
Yes.
Are there any other questions?
I just want to say one thing. I remember right from my PG, I've been looking at every Kaplan's comprehensive textbook that comes. We had a separate chapter on psychiatric rating scales in the textbook. It's not there in the latest edition, which was very shocking to me, and I felt sad about it because it's there in the scales are mentioned in every disorder, but they used to have a beautiful chapter in every textbook that covered all the scales. And I remember some time back, I don't hesitate saying this, Pharma used to give us books. There was a yellow book on psychiatric rating scales, which they had given us some times back. It's there in my library. But that also it was an exclusive compendium of these scales. But the latest Kaplan or the synopsis not having a chapter is something which I think I will write to the authors and tell them that it's wrong. The chapter should be there.
I couldn't agree more. Unfortunately, we are seeing, that suddenly even the resident doctors are, leaning more towards eminence-based psychiatry rather than evidence-based psychiatry. Eminence is something which you qualify for only if you have gray hair or you've lost your hair. Until that point in time, you have to go by evidence, right? And even then, you have to couple eminence with evidence. You cannot just assume that what you know is right. So Avinash has rightly pointed out that rating scales is a very objective way of being able to evaluate our patients. And unfortunately, we were trained. It was ingrained into our systems that you have to apply these scales. And I think the more you apply these scales, the more it gets ingrained into your system. And so that becomes a part of your repertoire with your patients. So that's a very important aspect of your training as well. You get more, sort of compliant with your assessment tools. You don't miss out on a few nitty-gritties, which in a busy day in the OPD, you might just probably just not notice, or it might slip you by. So yeah, I think Avinash did a fantastic job in trying to reiterate the significance of rating scales in psychiatry. And I would urge all the resident doctors as well as all the consultants as well. We have many consultants who are a part of this forum as well now with the ever-increasing popularity of our speakers. So all of us should. And Avinash rightly pointed out that it used to be a part of the curriculum. For some reason, it's kind of suddenly just slipped out. So yeah, Avinash, you wanted to make...
I want to also say one thing. I think, one of your mentors and my mentors, that is Dr. Ravindra Kamath, when I was studying under him, I remember he told me, Ki, Avinash, go and find out all the different rating scales available. And it was in a semi-internet era, I would put it. We didn't have the internet as much as we had it today. And I remember I got around 100 different rating scales Xeroxed. And we had kept a box file in the ward so that, the moment any patient comes, the scale is available. And, we could go in the evening at 5:36, apply it at our leisure, understand, and the next day discuss. I think this is something which today's residents, rather than have the scale on their phone, I think having a physical copy of the scale is something which is very important, because that gives you an idea. And the moment you use the scale, you are told that, you will sort of, and we had kept three copies of each scale, so that the moment, and you would mark with pencil and then rub it, check again. That was the way we sort of studied, which I think is not there today, which should be there.
There are a few books on rating scales. I'm actually looking at one right now, which is on the current clinical psychiatry clinical rating scales and assessment tools, right? So there are many such books, handbook of clinical rating. So if anybody is interested, they can reach out to us, and we'll probably send those books to you in the PDF form. So it's easy. The physical copies are not very easy to come by these days, like Avinash rightly pointed out. But there are a lot of good books. I will post it on the postgraduate through groups as well. But if anybody is interested, they can reach out to us, and we'll see what we can do to help our PGs get a little more acquainted. But yeah, thank you, Avinash. A fantastic job.
In the old exams, this used to be told to us that it would be an essay question.
Right, sir. Right.
In our days, it was a mandate to use these scales in our day-to-day ward work. And in fact, now the skid is not very frequently used, but I think in my book, the skid too. In our days, we had the DSM-3 TR and the DSM-4 come by. So I'm a little old school in that sense. But in those days, the way we would understand different clusters of symptoms and the access to diagnosis, which again has now become defunct. The skid trained us so well. So we were mandated to conduct the skid on all our patients, irrespective of the diagnosis they came with, unless they were grossly psychotic at that point in time and they were not in a position to be able to assess. But otherwise, that was what actually helped us, understand how personalities are, and actually it's basically just a DSM-based questionnaire, the skid. But if you do it often enough, then you start being able to pick up the nuances of the various personality types and to be able to do a very quick bedside assessment of the personality types, which I think we greatly underestimate, in the importance of our day-to-day psychiatry practice.
But I would like to add one more point over here, sir. I remember it very well. When I was doing my PG at DY Patil, Mumbai, memory clinic was started, under Rashmin sir's guidance. And I think so every Friday we used to have geriatric or memory clinic we used to run. And we used to score, or we used to do MMSE routinely, and we would keep that record, we would keep that sheet in the patient's profile or patient's file, so that it would become easier for us to compare with the previous MMSE scores. So whether the patient is having improvement with whatever treatment we have offered, is there any deterioration in his memory, or cognitive functions. So that was really helpful. And I think so till date, I'm practicing, in my clinical practice, because that was a habit which was, or a discipline which was given by Rashmin sir that time.
No, and we know the MMSE by heart, to be very frank. We don't need the scale, we could
absolutely.
Yeah.
In fact, I'm really proud to say that Nikhil was one of our first few students, and today he's a teacher. So it really brings a lot of joy to me to see that our students have reached a point where they are now teachers themselves, and it just reiterates the fact that I'm very old now. but it's nice to see that you still have carried on with those habits. It was in those days that we used to actually we started administering the neuropsychiatry battery, right? And we had Dr. Urvashi Shah, who's a very senior clinical psychologist, a clinical neuropsychologist. She's amongst the few people who pioneered that. So we used to actually have an entire neuropsychiatric battery, which was basically multiple scales. We had the CDI, the BDI, the ACE, right? The basic ones, which evaluated everything. So we had about...
And Pharma used to give us tearaway pads, of these rating scales at one time, rather than...
But we had compiled an entire set of tests that we would do on a very routine basis. Something as simple as even a BG, right? We would do at times because we'd be able to pick out things. So there were about 6 or 7 tests that were a part of that. And it was surprising how often the BDI would pick up the clinical depression, which was completely missed, right? And so many of these, when we would administer these scales, we would realize that they are probably depression manifesting as dementia, the pseudo dementia spectrum, as we might call it. And it also helped us understand the difficulties that patients with dementia had, and we would do a tracking on it. Every 6 months, we would administer the entire battery and then be able to chart the patient's progress or the deterioration, whatever the case might be. So clinical scales are very, very important in our day-to-day practices, though we might like to believe that we have a busy OPD, so we don't have the time for that. But unfortunately, that is not the right way to look at it. And it's a good thing that we had this talk today with Avinash, because he is, we need these kind of reminders and reiterations of the fact that it is a very important part of our scales in our practices, right? Like a diabetologist would mandate that every 3 monthly follow-up will have to have an HbA1c. In a similar manner, we need to start having certain basic screening tools, and we don't have to administer them ourselves. We can train our staff to be able to do that before the patient comes in, or have our assistant doctors or resident doctors in teaching departments who are to do these tests for every patient at every follow-up, in the predefined categories. So good. Thank you very much, Avinash, for being with us today and talking about this very important topic. And thank you, Nikhil, for being with us today. Again, thank you, because a double thank you to you for agreeing to be with us, but also the fact that you made me feel really proud of you today. So thank you.
Thank you.
And,
Thank you so much. Thank you for the kind words.
And thank you, all of you, for being with us today, because without the audience, our efforts are not going to be as fruitful as they might be. Of course, the unflinching support that we've had from Sun Pharma for this lecture series, and we promise to bring you another exciting talk the next month around this time. And we hope that you continue to learn, continue to teach, and continue to be better psychiatrists and better clinicians all around. Thank you very much, and I wish you all a good evening ahead. Thank you.
Thank you. Thank you.